Our next speaker is Dr. Atul Dhage. His topic of interest is psychotropic medication induced sexual dysfunction. I call upon the stage Dr. Atul Dhage. Hello. Hello.
Welcome, sir.
Hello.
I want to introduce here Dr. Atul Dhage, sir. He is a consultant, neuropsychiatrist and sexologist at Mind Care Hospital for Mental and Sexual Health, Ratnagiri. He is having the fellowship in clinical sexology from Grand Medical College and JJ Hospital, Mumbai. Presented his talk at SASSM conference and DPA conference, ISMP, MM and Sexcon conference and other psychiatric conferences, having the award Best Emerging SME Healthcare Sector Award at Suction Summit 2023 New Delhi. Most Trusted Psychiatrist and Sexologist, Maharashtra 2024 at Pride Bharat Award Ceremony, New Delhi. Was one amongst the 70 candidates selected from all over Asia for professional skills and leadership training workshop at NIM HMS Bangalore in 2014, which is the Apex Institute of India related to the mental health. Current president of the IMA Ratnagiri branch. He is a convener Public Education Committee of National IPS and Vice Chairman Mental Health Committee IMA MS. More than 100 articles related to the psychiatry and sexology in prominent newspapers of Maharashtra. Invited as a speaker for numerous programs of Air India to talk about the topics related to the mental health and the sexual health that were broadcasted throughout the Maharashtra, and invited as a speaker on Doordarshan TV network. And started running unique programs like Mind Care Express, Mind Care Marathon, Jagar Mano Arogya for awareness about mental health. Yes, you can continue.
Thank you, sir. Thank you for the introduction. At the outset, I would like to thank organizers for giving me this opportunity. This lecture was a workshop that I conducted 1 year back in one of the conferences, which was of 3 hours. So it's difficult for me to cover in 15 minutes, but I will try to do that. I will try to deliver the best. What I will do is I will give you 5 slides or 5 cases. I want non-psychiatrist sexologists to answer those. Like what will be the probable diagnosis and what will you do? So be ready. First slide is 33 years old man comes to you. He is taking Lexito 5 milligram, that is escitalopram, since 2 months, prescribed by general practitioner. Known case of depression with complaints of decreased interest, sadness of mood, disturbed sleep, decreased desire, poor erection. What will you do? Non-psychiatrist sexologist. Just give spontaneous response or immediate response.
We will stop the Nexito.
I will stop Nexito. Okay. Let's see. Any other response? Okay. Case 2. 35 years old male working as a software engineer in Pune and comes to Ratnagiri every week. Known case of obsessive compulsive disorder and depression. Maintained on fluoxetine 40 mg in morning and rospital plus 2 mg, that is respirator and triacifridine half at night. And he is complaining of erectile dysfunction. What will you do?
Hello. Hello.
Respiratory causes low libido.
Sorry?
Respiratory 2 mg, no?
So what will you do?
So we should.
You will stop the respirator.
No.
Less prolactin.
No, just what will you do? I don't want pathology or mechanisms behind that.
Only thing is we just decrease the dose.
Decrease the dose. Okay.
Alternative.
44-year-old male, known case of mania, that is bipolar mood disorder. He is on treatment, maintained since 1 year on treatment, tablet divalproate 500 mg at night and tablet lithium 400 milligrams HS. Came to sexologist complaining of erectile dysfunction, says he is not getting proper erection and can't satisfy his wife, so needs medication for self. Wife says there is no problem and they have sex almost 4 to 5 times a week. What will you do? I want answers from my non-psychiatrist.
Placebo, give placebo. Wife says everything is normal. Give some placebo at bad time.
Okay, give placebo. Any other response? Yes, SSRI चालू करेंगे. Okay. Case for 25-year-old young married female with predominant negative symptoms than positive symptoms of schizophrenia during the preceding 3 to 4 years. She was on treatment Rospital plus 2 and Sulpitab 200 and also on fluoxetine 60. She is overweight with irregular menstrual cycle with history of amenorrhea. She had complaints of reduced interest in sex since last 6 months. What will you do?
Weight loss.
Sorry?
Weight loss.
Weight loss, okay. Any other response?
She needs psychosexual therapy.
Lab test, okay.
Cycling hormone therapy.
Filbenserin has some window of use in such case.
Okay, let's see. And then this is the last case. A 45-year-old married female with complaints of sadness, reduced interest, disturbed sleep, episodes of palpitation, chest discomfort and worries about family's future for the past 2 months. The patient was started on Zosur 25 mg, which was increased up to 125 milligrams per day and an oral clonazepam 0.5 milligrams per day. With this, she experienced improvements in her sleep and mood and reduction in anxiety symptoms as well as worry. During the follow-up after a period of 3 months, the patient reported reduced pleasure on multiple occasions of sexual intercourse. Her menstrual cycles were irregular. What will you do?
Regular.
Okay. So take proper history and physical examination and investigations. So before blaming psychotropics, as someone said, stop Nexito 5 mg. Nexito 5 mg is very small dose. It can't cause sexual dysfunction. You in the second case also you said that Rospital plus should be stopped or dose should be decreased. So before blaming the psychotropics, you have to consider the many things. Why I chose this topic in last conference also or in this also is because I see in many conferences those who are non-psychiatrists directly says stop antipsychotics, stop antidepressant. अरे बाबा इतना इजी नहीं है वो. अगर पेशेंट, well, I have seen patient who had done suicide. He was suffering from depression. He was maintained well on the antidepressants and someone stopped antidepressants and patient committed suicide after 1 month. So it's not so easy to stop any of the psychotropic medications, and my whole intent was to just before stopping these or handling these cases, you should have some liaison with the psychiatrist. So think about these things. Are there any social issues? Are there any interpersonal issues between husband and wife? Is there any history of substance use disorder? Is there comorbid medical condition? Is he taking any medications for diabetics, atherosclerosis, CVA, any other medications which can cause sexual dysfunction? So what comes to people's mind or technicians' minds before anything is antidepressant है तो इसकी वजह से ये sexual problem हो रहा है, so stop it. So don't do that. As a sexual dysfunction can be a clinical symptom of mental disorder itself, like depression, negative symptoms of schizophrenia. It can cause sexual dysfunction. So take a temporal relation of the sexual complaints with the onset of the symptoms of any of the psychotic disorders or depression, or after starting the medication. When did this sexual symptoms started? So think about this. Was patient sexually functional before the current episode of the mental disorder? If the answer is no, then you have to think that sexual dysfunction was the prior thing, and then depression or other could have been developed after that or because of that. Is there any history of sexual dysfunction in related to mental disorder? So you have to draw a timeline and you have to find out where does this exactly started. As a part of psychological and socio-cultural burden of the mental disorder. Many times when typically patients are schizophrenic or suffering from bipolar or mood disorder, so their partners could have negative attitude towards them and they themselves don't have interest in the sexual initiations or sexual acts. So this can have this can cause problems and can cause sexual dysfunction. Whether sexual dysfunction is due to rejection by sexual partner. How does being mentally ill influence patient's self-esteem? This is very important. And initiation of sexual encounter. So you have to think about these things. Is it a part of medical burden of mental disorder? You have to think about this. Then this what you are thinking typically is this, that it can be a part of medical burden of mental disorder. Lab tests should be done to assess influence of medical factors like diabetes and other things. Referral to other specialists if comorbid medical disease. If patient is having depression, diabetes or hypertension, then you should talk with that specialist or physician and see what is there any antidepressant or medication which is causing this sexual dysfunction before stopping the antipsychotics or antidepressant. Is it medication related side effect? Is onset of dysfunction is related to onset of disorder or initiation of the treatment? Does the dysfunction correspond to mechanism of the medication? This is also important. What is the mechanism of action of that drug? So, if कोई medications है जो antipsychotic है, antidepressant है, but that can't cause sexual dysfunction, then why to stop? Like vilazodone, if someone is doing that vilazodone or melatonin, these medications are giving just because they are prescribed by the psychiatrist, that doesn't mean that these medications are causing sexual dysfunction. So think about this. Is there mechanism of is it because of the mechanism of that medication? Is occupancy of dysfunction related to increasing the dose of the medication? You have to think about this. Is particular medication related to dysfunction? Sometimes we have to prescribe, psychiatrist has to prescribe 3-4 medications at a time to the patient. So instead of stopping all the drugs or blaming all the drugs, think about it. Is there any of these 4 medication which is causing actual sexual problem? So have liaison with the consultant psychiatrist. Can we decrease the dose? Can we stop the dose? Don't stop all the drugs at a time, because all the previous 3 drugs could be good and patient was maintained on that, and because of just 4th drug this has been caused. So removing that 4th drug can itself give a result, better result, and patient can be well maintained on those medication. Was dysfunction present during previous medication? You have to think about this. Like as I said, if there are 4 medications, now there were 3 medications previously and patient is maintained on that, there was no sexual dysfunction, then why to stop all those previous 3 medication if patient has not having sexual dysfunction with this previous medication? So all routine investigation needs to be done. Investigations to rule out medical disorders should be done, and specific test for sexual dysfunction has to be done. I will skip those this slide because we don't have too much time. Before confirming the diagnosis, think about this chart. Think about the biopsychosocial model, because we know that sex is not between the 2 thighs, it is between the 2 ears. So psychological factor is very much important. So is there any individual biological factor? Like as I said, medical disorders can cause these problems. Medications given for the medical disorder can cause this sexual dysfunction. So then again, coming to last, psychiatric medications given for the psychiatric disorders like depression or schizophrenia can cause this problem. So think about this biological. Is there any biological predisposing factor, precipitating factor, and maintaining factor? So see this chart, where does this fit? Then think about the individual psychological problems. As I said, patient have low self-esteem, patient have guilt, patient have low confidence. So in this case, you need to correct that. If there are interpersonal issues with the couple, between the couple, then you have to do the counseling. You have to say to the partner that having just schizophrenia or mania doesn't mean the patient is gone case or something like that. he can do the well in the society, and they can have good relationship. And family social issues has to be done. This is the implicit model. I hope many of you know. I will go to this treatment algorithm, and then we will jump to what should we have been done all those specified cases. So confirm the diagnosis. If the patient is new, look at modify. Is there any stressor? Is there any lifestyle modification that we can do? If patient, and wait and watch for 7 days. If patient improves and sexual dysfunction disappears, then you can continue the same medications. If the patient is old and the sexual dysfunction is not improved in the new patient, reduce dose to the minimum effective. You need not stop all the medications, or you need not stop that medication suddenly, abruptly. You can reduce the dose to the minimum effective level, and then continue the minimal effective dose if there is improvement. If there is no improvement, you can think of the drug holidays. Some literature mentions this, but none of the psychiatrists I think nobody practices this drug holidays, because we know the severity of the mental disorders that can cause to the patient. If it improves, continue same strategy. If not, adjunctive treatments like sildenafil, tadalafil we can use, or dapagliflozin we can use. If patient improves, we can continue the combination. And even after this, if patient doesn't improve, we can stop that medication, and we have to think about the other class medication, like other class of antidepressant which can't cause sexual dysfunction, or other class of antipsychotic medications which can't cause this sexual dysfunction. So coming to the case first was next to 5G. It was very less depression, and in this case the reason was sexual dysfunction itself. Because of patient was having erectile dysfunction, reduced desire, he developed depression, and he was taking treatment from the GP, which was just 5 mg, which has like a placebo effect. It doesn't work that much. So we have to increase the dose. Rather than stopping the Nexito, we had to increase the tablet Nexito or escitalopram in this case. I will don't bombard you with these studies or something. The second case was of OCD, coming to the once a week in Ratnagiri. So you can't stop fluoxetine in this case. We have to just 2 minutes. So we have to take detailed history. So OCD is the most difficult disorder to treat in the psychiatry. And patient was maintained in just 40 mg and half of the hospital base, which is the minimum dose we can give to the patient. So you need not stop in this case. We need not to switch. We just can add tablet tadalafil. Patient used to come once a week. So take tablet on the Saturday when you come. You enjoy on the Saturday and Sunday. You can go back. So instead of stopping, this could have been the strategy, that is adding the medication. In this third case, instead of stopping divalproate and lithium, we had to take the detailed history. Is it a case of hypersexuality, or patient is switching to the mania, or patient has this relapse of the mania, because patient is having hypersexuality. Wife is saying they are having 5 to 6 times. So in this case, it was a relapse of the mania, and instead of stopping the medication, then we need to increase the dose of the lithium or divalproate. And for that we can give, as someone said, it was very right, we can give just placebo, or we can give tadalafil if still he demands. In the fourth case, this was the actual case, like medication, antipsychotic induced sexual dysfunction. Here, sulfitac and rospitril both were causing decreased desire, because there was amenorrhea, there was increased prolactin. So in this case, yes, this has to be, I will say, instead of stopping, we have to taper the dose, we will have to decrease the dose, and see, as mentioned in the second or third step, that we have to bring her to the minimum effective dose that can improve the sexual function, and patient will be maintained on the treatment.
Sir, please.
Yeah, just last case. So this was the fifth case. This was actually a antidepressant induced sexual dysfunction, because patient has developed it after taking sertraline, and it was very much possible that it can cause sexual dysfunction. So we can consider shifting to the antidepressant that will not cause sexual dysfunction. So we can prefer agomelatine, glucopropan, mirtazapine, nefazodone, trazodone, vortioxetine. So I will come to the end. before we blame psychotropics, psychiatric, these all things has to be considered. As I said, the take home message is take detailed history. It is very much important, and see temporal relationship with the disorder, understanding both the impact of a disorder and the effects of treatment you should look for. It is important for the clinician to acknowledge and encourage discussion. This as a basic model we have to give permission in the first stage that you should discuss about this issue. Always have a license with treating psychiatrist before stopping any of the psychotropic medication. And if you are that much interested in doing that, study more about the psychiatry. Thank you very much.
Thank you, Atul Dhage sir, for nice presentation.